Okay, Bismillah ar-Rahman ar-Rahim. Good evening, everybody. Today we will have our first lecture in English language, and we will talk about very important topic, which is the management of acute diarrhea in children, of course. The objectives of our lecture today is to, first of all, have a look on the definition of acute diarrhea, and then how to make an assessment to a patient who has acute diarrhea. Then we will have a look on the principles of the management plan of acute diarrhea, and then we will discuss the need for the use of antibiotics in acute diarrhea, and then we will have few clinical cases of acute diarrhea, and we will look how they are managed. It's important to know that in spite of that, this topic is easy, but it's very important if we know that every year 4 million deaths in children are attributed or caused by acute diarrhea. Most of them, 85% of them, are infants during the first year of their life. Most children, actually, each child during the first 5 years of his life will have about 7 to 15 episodes of acute diarrhea. According to the recommendations of the WHO, it's very important to improve pediatrician and clinician practice dealing with acute diarrhea, because if we only improve the practice of pediatricians dealing with acute diarrhea, we will achieve decrease about 30% in the mortality and morbidity of childhood in general, because it's a leading cause of death. So what's acute diarrhea? The simplest and most approved definition of acute diarrhea is loosey motions twice the usual number per day. So there is no fixed number to all children. It depends on how much usually this child pass stool a day. And if he's past 2, then the definition for him is 4. If he passed 4, then the definition for him is 8, and so on. And it should be loosey, of course. The causes for acute diarrhea mostly is infectious, could be viral in most cases, or bacterial, or due to parasite, or could be extraintestinal infection like urinary tract infection and acute otitis media, meningitis, and pneumonia. Or it could be non-infectious at all, like food allergy and food intolerance and toxins, of course. The main issue in acute diarrhea is electrolyte loss. For example, in cholera, if we have a comparison between the main cause of secretory diarrhea, which is cholera, we find that the child will lose about 100 millimole of sodium in each liter of stool. It's almost double the amount of sodium which is lost in other causes of diarrhea. The same can be said regarding other electrolytes and bicarb. The most important issue here in the management of acute diarrhea is how we will make assessment to a child of acute diarrhea. When we are dealing or examining or evaluating a child with acute diarrhea, we need to achieve 3 targets. The first is to assign the level of dehydration. Then we need to exclude extraintestinal infections, and then we need to exclude the need for antimicrobials. To achieve these 3 targets, we need to go on one by one. The easiest way to make evaluation of dehydration is to follow the WHO dehydration criteria, which is from 0 to 8. We look to the general appearance, eyes and tears, and the mucous membranes. It's simply like that. In children, it's enough to take only this simple dehydration assessment. Of course, each criterion here, or each feature, has 0 or 1 or 2 scores or 2 points. So if, for example, there is a child who has dry eyes, no tears, and dry mucous membranes, then we can say that he has a dehydration level of 3. And if the child dehydration from 1 to 4, it's mild to moderate. From 5 to 8, it's severe dehydration. After assessment of the dehydration, we need to fix the dehydration status, and we need to go on the rehydration treatment first, and then we need to give the maintenance hydration status. The rehydration depends on the level of dehydration, of course. If the child has mild to moderate dehydration, we can rehydrate using the oral rehydration solution. And it's better to start the rehydration phase by giving higher concentration of sodium, choosing the solutions which contains sodium 70 millimole per liter or more. While after finishing the rehydration and moving to the maintenance or recompensation treatment, we need to use the solutions which contains lower concentration of sodium between 40 to 50. When we reach, of course, if there is mild dehydration, then we need to give 50 ml per kg. If there is moderate to severe, we need to give 75 up to 100 ml per kg of the oral rehydration solution. It's recommended to give it slowly, start very slowly, use a dropper or a spoon, and take your time, about 4 to 6 hours, to give the rehydration by the designed amount by the oral rehydration therapy. If there is vomiting, it's recommended to give 1 or 2 doses of ondansetron. It may be one of the rare medications recommended to be given in the management of diarrhea, other than the oral rehydration solutions. For the recompensation, for each episode of diarrhea, it's recommended to give 10 ml per kg of the oral rehydration solution. And for each episode of vomiting, it's recommended to give 2 ml per kg of the oral rehydration solution, of course. If the child has severe dehydration, the WHO recommendation is give 30 ml per kg of normal saline during the first hour. After that, evaluate the patient for dehydration, Phoenix score, and collect samples for kidney function and electrolyte, random blood sugar, lactate, venous blood gases, anion gap, calcium, blood count, C-reactive protein, and then urine analysis and stool PCR for pathogen isolation. So in severe dehydration, we need to make a study, but first you need to give the 30 ml per kg of normal saline within the first hour, of course. After that, during the next 5 hours, we need to give 30 ml per kg of normal saline, which is the deficit, plus the maintenance for the 5 hours. As all of you know, for each kg from the first 10 kilos of weight, we need to give 4 ml per hour from fluids as a maintenance. And for the next 10 kgs, we need to give 2 ml per kg and 1 ml per kg for each kilo after the first 20 kilos. Of course, the fluid which is used for the maintenance should be 1/2 normal saline in D5, plus or no, or with or without potassium chloride, according to urination and potassium level, which is already checked. So when we finish the first hour, then we need to move a mixture of fluids using both normal saline to continue the rehydration and the maintenance, which should be 1/2 normal saline in D5. Both of them should be mixed and prepared together. After that, after the 5 hours, we need to repeat evaluation for the dehydration level, Phoenix score, and lab results. After that, then we need to decide what we will do. If the child has improved, the dehydration became mild to moderate, and the lab results are reassuring, acceptable, and the child has no vomit and no sepsis score, then we can send him home on oral rehydration solution and nutrition support. Of course, fasting is banned completely. And we have to educate parents about the alarming flags when they need to come back, when, for example, there is vomit, or when there is apathy, dehydration, deterioration in the conscious level, or there is anuria for more than 8 hours, or other complaints like convulsions or other alarming signs. So parents' education, oral rehydration solution, nutrition support, and of course, we have to make our decision if this child needs to be given antibiotics or not, according to, as we will explain later. But if the child needs admission, it depends on his dehydration. If we give fluids after the 6 hours, the child still dehydrated, there is vomiting, there is Phoenix score 2 points or more, there is critical labs, then we need to admit the child, refer him to the PDF floor or the PICU according to his status, continue giving him IV fluids, and of course, no fasting. He should start taking the oral, continue taking or start taking oral feeding. The recommended fluids for after the 6 hours is to give the remaining 1/3. So if we see, according to the WHO recommendation, severe dehydration, the deficit should be divided on 3 parts. The first part, 30 ml, should be given during the first hour. Then 35 ml should be given during the next 5 hours. And then 35 ml per kg should be given during the next 12 hours. Maintenance should be added after in the second stage, which is from hour 2 till hour 12. And the maintenance should be given as normal saline in D5 plus sodium chloride. Let's have an example for that to make the issues clear, because it's very important for all of us. Let's have a child who is 7 years old boy. His weight is 22 kilograms and has severe dehydration. For this child, the deficit amount is 2,200 milliliter. And this should be given, of course, as normal saline, 0.9%. And the maintenance for this child is 4 ml for each kg for the first 10, and 2 ml for each kg for the second 10, and 1 for each kg after the 20. It will be 40 plus 20 plus 2, it will be 62 per hour. This is the maintenance in general. This one should be added to the deficit and be given during the periods, the 3 stages of rehydration. For the first hour, this child will be given 30 ml per kg. It's equal to 660 ml of normal saline should be given during the first hour. During the next 5 hours, this child will be given 30 ml per kg. It's equal to 770 ml of normal saline. Divided on the 5 hours, it will be equal to 154 ml of normal saline each hour, plus 62 ml, which is equal to the maintenance as it's calculated here previously. So this child will be given 216 ml of the mix, which consists of 154 normal saline plus 62 ml of 1/2 normal saline in D5, and of course potassium chloride should be added according to the level of potassium in blood. This mixture should be given continuously for 5 hours. During the next 12 hours, if the child is admitted, we will give him deficit of 770 FM normal saline, 77 ml of normal saline divided on 12 hours, which is equal to 64 milliliter per hour as normal saline, and a maintenance of 62 ml per hour. This will be from normal saline in D5. The total will be 126 ml per hour of the mixture every hour for the next 12 hours. Hope this way of rehydration is very clear for you. It's very important to improve our practice. And for me, I find the recommendation of the WHO is much better than all the other plans which is mentioned even in pediatric textbook. The next step is we need to evaluate if there is a need for antimicrobials. The vast majority of children who has acute diarrhea are without fever and older than 6 months and without extraintestinal infection. There is no known epidemic, and they need only rehydration and nutritional support, and of course, no need for any antimicrobials. This clinical picture is the most common scenario in acute diarrhea that we see in ER and clinics. Minority of cases only, we according to the WHO recommendations, will need antimicrobials. Of course, dehydration is not an indication for the use of antibiotics. And all cases of acute diarrhea during epidemics of a specific pathogen, like example, when there is cholera or Shigella, or like now we have salmonella, non-typhoidal salmonella, all cases should be treated as a probable cases unless the pathogen is isolated. When the pathogen isolation is not available, we need to treat according to the WHO recommendations. Diarrhea during travel to endemic spot or within 10 days thereafter need antimicrobials unless excluded by negative pathogen PCR. Red flags for antimicrobial need, not use. When the child has one of these criteria, we need to evaluate him for the use of antimicrobials or not. If there is a prolonged diarrhea, more than 10 days, or the infant is less than 6 months, if there is acute febrile diarrhea, there is a bloody mucoid diarrhea, there is epidemic or travel to endemic area, there is immunodeficiency or malnutrition, or there is criteria for extraintestinal infections. When there is one of these criteria, we need to evaluate a child for the use of antibiotics or not. We will see how we will do that later. Most common extraintestinal infections associated with diarrhea, and we have to take care of them, is urinary tract infection, acute otitis media, meningitis, and pneumonia. Red flags for extraintestinal infection: if there is diarrhea, if there is no diarrhea, or the diarrhea is much less than the dehydration. For example, if we find moderate to severe dehydration and the child passed only 2 or 3 loose motions, so we have to think about infection extraintestinal, not acute gastroenteritis. If the Phoenix score is positive, we have to consider extraintestinal infections. If there is other symptoms like rash, purpura, there is a clear focus of infection like convulsions, focal neurology signs, nocal rigidity, altered conscious level, bulging fontanelle. These are clear findings of focal infections. Or there is abdominal rigidity, or there is clear otitis media, or findings of pneumonia. Acute febrile diarrhea usually is due to invasive pathogens like viruses or bacteria. So it's usually associated with bacteremia, or could be associated with toxin-inducing bacteria infection or due to extraintestinal infection. So we have to take care of acute febrile diarrhea and make very good full evaluation to the child to exclude the invasive infections, bacteremia, toxins, or extraintestinal infections. And we have to remember that simple gastroenteritis usually don't cause high fever and don't need antibiotics, even if it's bacterial in the immunocompetent child. We mean by fever, as we said in the previous lecture, that it's documented temperature 38, more than 38.5, should be 38.6 or more. And it should be confirmed by a medical staff. And we said in the previous presentation that the best way to make microbial isolation is the PCR on stool. It's better, much better, more sensitive, more specific than the cultures. When we find a criteria for the need of use antibiotics, for example, a child with fever or a child with a mucus and blood, we need to make a primary assessment. It's obligatory, if it's possible, of course, and not go directly to the WHO recommendation and treat empirically with the recommended antibiotics. If you have the ability, then make a primary investigations, make primary lab assessment, which is white blood cells, CRP, and procalcitonin. It should be considered a clue to start the antibiotic, or there is a need to give antibiotic if the white blood cells more than 15,000, CRP more than 15, procalcitonin more than 0.5. And for me, I recommend not only one criteria of them to be positive, I recommend both of them, two of these three criteria to be positive to go to the next step, which is the pathogen isolation. So I will make, for me, I recommend making the white blood cell, CRP, and procalcitonin if it's available. And two of these three criteria should be positive in a child who has a need red flag, for the use of antibiotic. Then if two of these three criteria is positive, then it's recommended to make pathogen isolation using the PCR on stool. And if it's possible, to make stool microscopic examination to rule out associating parasites, which could be available sometimes or could be reactivated with bacteria. And we need after that to start antibiotics according to the results. So let's summarize the need to use antibiotics by, if the child has a clinical indication to use to the need of antibiotics, then we need to make a primary laboratory assessment. If there is two criteria positive and we have the ability to make stool PCR, this is the first way to make our decision very clear. If we don't have, then we go directly with the WHO recommendations. If we have the ability to make stool PCR and we have the ability to make pathogen isolation, we need to give antibiotics according to the pathogen. If the child has cholera, Shigella, typhoidal salmonella, non-typhoidal salmonella, if it's invasive or after travel, Campylobacter, and some parasites like Giardia, amoeba, and some other rare parasites like Strongyloides stercoralis and others. Other bacterial etiologies are not indications to give antibiotics. For viral diarrhea, only there is paucity of recommended medications. One of them is approved, is the racecadotril. Racecadotril is one of the enzymes inhibitor. It's not a direct antiviral medication, but it's decrease the secretory diarrhea and improve reabsorption. And it gives a very good clinical effect, decreasing the duration of diarrhea and decreasing the fluids loss and electrolyte, of course. Probiotics and zinc, not recommended anymore, unless there is malnutrition or there is travel history for the probiotics. There is a good study and there is a primary recommendation, not yet approved by the FDA, about using the nitazoxanide for rotavirus for 3 days. It's mentioned in many studies, very effective in rotavirus, acute gastroenteritis in particular. Now we will move to the second part of our presentation today, and we will have a few cases of acute diarrhea, and we will discuss with you how it's managed. So the first child, do you want to stop here or have some conversation?
If possible.
If possible, yes. Okay.
Thanks, Dr. Jihad, for interesting presentation. Can I give a question?
Yes, please.
It is best to give ondansetron IM or orally?
First dose, if the child has vomiting, it's better to be given intramuscular. After that you can give it orally, the second dose, if you need a second dose.
No more than 2 doses?
The recommended doses for mild to moderate is only 2 doses, yes. If you fail, the strategy to control vomiting in mild to moderate diarrhea, mild to moderate dehydration, is to give the assigned amount slowly and use the spoon or dropper, give it very slow and increase the amount gradually. Take your time. The target is to achieve the rehydration within 6 hours. You have good time. This is more effective than giving antiemetics.
Okay. In daily practice, when we suspect parasite infection, how to approach it and how to manage? We had over diagnosis to parasite infection or under diagnosis.
About parasites, it should be confirmed by stool exam. Other than that, it should never be treated. And you don't need a lot of complex utilities to confirm the diagnosis of acute parasital diarrhea. Even by light microscope, you can see if there is amoeba or giardia. This is the most common to give treatment for parasital infection, acute diarrhea. Other causes, I don't think it's a cause, and it should be also confirmed by the stool exam. If there is a heavy infection by parasites like Stercoralis or others, Strongyloides stercoralis or negators or others, also you need to confirm it by the stool exam. The only approved method to confirm the parasital infection is a light microscope. PCR may be helpful, but it may be positive even after the recovery. And we say that, for example, if the child has a PCR positive for giardia and you treat him, the PCR in stool may continue to be positive for even weeks after finishing the treatment, and this is not an indicator of treatment failure. So, if to put a diagnosis of parasite-induced acute gastroenteritis and treat it, you need to confirm the diagnosis by stool examination using the light microscope, of course.
When I suspect it, only if persistent diarrhea?
Even if you suspect it, it's very easy to make the light microscope of the stool. You don't need any, it's easy and affordable everywhere. It should be like that. You can't treat a clinical suspicion of acute giardia and treat it without positive result on clinical grounds only. If you
Sorry,
don't have any, if you don't have any facility to confirm the diagnosis, then you can treat it clinically. Is it the question like that?
Sorry, I asked about when I suspect parasite infection.
When you
Persistent diarrhea only, more than 2 weeks.
For me, the two most important parasites that need treatment should be amoeba and flagella. Clinically, when there is travel history, when there is acute diarrhea without fever, if there is offensive smell, if there is a mucus or blood, or both of them in the stool. These criteria without fever could be a clue to a parasite infection, but I will never treat without stool exam, of course.
How about diarrhea? How about persisting diarrhea more than 2 weeks?
That is another issue, and as we said, it's an indication to make pathogen detection by the PCR and the stool examination, of course. Even if the child has no fever, if there is diarrhea more than 10 days, even not necessary to be 2 weeks. Diarrhea more than 10 days, you have to make stool PCR and stool examination. If you don't have the ability to do those at all, then it's another issue. It's another issue. You need to treat empirically.
Thanks, Dr. Jihad. Sorry for serial questions.
No, it's good question. It's important for all of us. We may find such patients every day. We must put a line between what's recommended and what's available. The recommended in such case, it's a red flag to make pathogen isolation. If you have the ability, you have to do it. If you don't have the ability, then go with the WHO recommendations. WHO recommendations is to give antibiotic in such cases. Okay. So let's go to the first scenario. Okay, do you hear me well? Voice is clear? The first case is a 5-month-old baby attended to the ER, apathic, with sunken eyes and decreased skin turgor. In a hot summer day, he had vomited five times, but no diarrhea. His heart rate is 150 and respiratory rate is 50. And main arterial pressure is 50. This baby has one or more of the following. You can choose one or more of the following: sepsis, septic shock, SIRS, shock, severe gastroenteritis. So I need you to just to help me, give me a few suggested answers. We have a 5-month-old baby attended in a criteria of severe dehydration, okay? In a hot summer day, he has vomiting 5 times, no diarrhea, heart rate, there is tachycardia, tachypnea, increased capillary refill time, and low main arterial blood pressure. This child has one or more of the following: sepsis, septic shock, SIRS, shock, severe gastroenteritis. Yalla, need answers? Okay, very good. I have one good answer here. If we will go to the management steps of acute diarrhea, as we said, first, before giving definition of the child status, we need to give 30 ml per kg of normal saline. And then we need to go to the assessment of the Phoenix score, taking samples and do other steps. So we can't say for this child that he has sepsis, even if he has one or more criteria of the Phoenix score at this stage. So the simplest definition for this child is that he has shock. The correct answer is D. This child has severe shock, mostly hypovolemic shock, but I'm not sure. If this child has sepsis, SIRS, or septic shock, it's not a good time to give the decision according to this. Of course, he doesn't have severe gastroenteritis, so E is incorrect. Did you get the idea about this question? When you find a criteria of shock in a child who is severely dehydrated, you should not rush and say that this child has septic shock or has sepsis before giving him an aid, a primary rehydration, at least for 1 hour. Please go back to the steps that we mentioned in the treatment of severe dehydration. So, oxygen 100% was given by mask to this child, while IV line instilled and then given 20 ml per kg of normal saline, which was equal to 100 ml. What you should do next? So he was given bolus, 20 ml of normal saline and oxygen. What you should do next? Give antibiotics, give another bolus, chest auscultation, intubate the child because his saturation in room air is 88. Take samples for septic secrete. Please, suggested answers. You decided that this child has hypovolemic shock, and you started to giving him fluids by bolus. What's the next step? Did you finish giving him fluids? Are you sure that 20 ml is enough? Actually, the correct answer is here. You have to make chest auscultation. So please keep in your mind, after each bolus, you have to evaluate 2 things: heart rate, respiratory rate, and chest auscultation. This is a cornerstone in the management of rehydration by IV fluids in shock or other situations, but mainly in shock. Start by giving bolus. The next step is to make chest auscultation. Okay? So the correct answer is C. You did chest auscultation and you find that the lungs are clear, and you decided to give the second bolus. You give the second bolus. The second bolus was given 20 ml per kg, but also no change in the previous vitals. Heart rate, respiratory rate, capillary refill time, mean arterial pressure, all the same. Okay? All the same. What you should do now? Please put these tips, these suggested, choose one of these suggested help. Give epinephrine and admit the child in PICU. Intubate the child. Give third bolus. Chest auscultation. Give noradrenaline. So you give 1 bolus, make chest auscultation, lung clears, but your child not improved, and you move to give the second bolus because your child not improving. You give the second bolus. What you will do next after the second bolus? Intubate, give third bolus, Chest auscultation, give noradrenaline, give epinephrine. Suggested answers? The purpose of chest, yes, the correct answer is B, of course. Again, I will repeat this critical advice. After each bolus, chest auscultation is obligatory to see if there is crackles or there is a fluid overload. You don't need to give a large amount of fluids to accumulate in the lung, because in most cases of shock, the cardiovascular fitness is poor, and the card job as a pump, it could not be enough to circulate and distribute the fluids very well all around the body. Most of them will go to the minor circle and accumulate in the lung. So you have to pay attention, be careful, and listen very well to the lung. You should be slow if you need to be slower or discontinue completely giving the fluids. It's very important to evaluate after each bolus. Evaluate two things: vitals and chest. So the correct answer also is chest auscultation. You make chest auscultation and you find that there is no lung crackles, the chest is clear, but the vitals is still the same. And the saturation, even you are using 100% oxygen, is 92. Now you need to go in more advanced steps. Could you please put these interventions in the correct order? So if the child is not improving on one step, you need to jump to the second step. These are the suggested steps. I need you to put them in order. This is very important question. You have no time to think, you have time to make decisions. Okay? You give the first bolus, no improve. You give the second bolus, no improve. Lungs, no crackles, still clear. Vitals, still poor, no improvement. What should you do next? Next and next and next, all of them. Put them in order, please. Suggested answers, and after that, we will discuss that. Put all of them, please. You need to put all of them. I know it's not easy question, but it's very important in our practice. So you give two bolus. What you will do now? Is it wise to give third bolus? No. So what's the recommendation now? To give vasoactive agent. Which one is the best? Adrenaline, noradrenaline, or milrinone dopamine? Adrenaline. Yes, B. So the first one should be to give the adrenaline or adrenaline. Then if he's not improving, then you will jump to the second vasoactive, which is milrinone and dobutamine. Milrinone is better. But if you don't have, you can give the dobutamine. You give, and your patient is not improving. Then you need to think about the third bolus. But before giving the third bolus, you need to intubate. You need to intubate. So the correct order should be to give the two vasoactive agents, BC, and then you go intubate, and then give the third bolus, and then give hydrocortisone, and then give mechanical ventilation. Of course, you don't need to give all of them. In most cases, you will jump to in one or two steps rarely 3 steps, and extremely rare you will go to the third bolus and mechanical ventilation. But you need a plan how you will manage with such a case of severe dehydration with shock not improving in the primary steps of treatment.
Sorry,
It's okay.
Can
so
I
in general,
ask
we can,
a question?
if it's related to the case, yes.
For the first bolus, normal saline, is it after or before vaso agents?
It should be after, of course.
Vasoactive agent.
The only exception, if you have a clear cholera. If you have cholera, then you may need to give a third bolus before the vasoactive agent. But if you don't, which is of course very rare, in our case, the child has no diarrhea. So it's not recommended at all to give a third bolus. If we are talking randomly in hypovolemic shock in general, it's not recommended to give a third bolus at all before giving 2 vasoactive agents. If the case is refractory to IV fluids, to 2 bolus and and vasoactive agents, then you may think about a third bolus. But that should not be given in the ER at all. It should be given in the PICU under intubation procedure. Okay, unless of course you are dealing with a cholera case, then the situation is completely different and you can give third bolus. Is it clear, Doctora?
Is it different from septic shock? In septic shock,
we are in septic shock.
definition,
In septic shock, we should be more strict. We need to make strict evaluation after each bolus, and of course, after 2 boluses, you need to give vasoactive agents. Don't give third bolus. The main issue in septic shock, the main issue in septic shock. Sorry, there is a problem with the internet. I didn't hear you, Doctora. Sorry. Doctora,
I remember that in septic. Do you hear me?
Yes, I hear you now.
Do you hear me, Doctor?
Yes.
In septic shock, in definition, is it there is hypotension, although give 60 ml per kg. I remember that. I don't know. What is your opinion?
I didn't listen to the most important part of the definition. There is interruption in the internet. By definition, I don't know from where you get this definition. But septic shock, we don't consider the amount of fluid you give that to consider it. According to this definition of septic shock, it should be according to the Phoenix score only in pediatrics. We need to ignore all other definitions of septic shock. But for example, if this is true, so all cases of severe dehydration which needs more than 2 bolus should be considered septic shock, which is not practical at all. Septic shock should be put only according to the definition of Phoenix score. Let's make a small comment about the septic shock here. In septic shock, it's not a problem of hypovolemia only. It's mainly distribution. There is a maldistribution of fluids in the body, not necessarily to be hypovolemia. Maybe the intravascular volume is low, but the total body volume of fluids could be normal. So it's not an issue of hypovolemia. And that's why even from the first bolus, you may cause lung edema. So we need to be more strict in septic shock when introducing the fluids, bolus. We may give even less than 20 ml per kg per hour. Exactly so similar to that in cardiogenic shock. I hope the idea is clear. And if we need a comment, we can make that later, okay? By the way, I don't bring I don't put my opinion in the material that I give you. When I tell you something that this is from my own practice, it will be extra and I will mention it. But the steps that I mention here is recommended in the principles of advanced pediatric life saving. Okay, it's in the American College of Cardiology and also in the principles of PICU, which is employed by recent guidelines. Some shock tips here in general. First of all, you have to offer oxygen and protect airway. Then you will give the bolus IV fluid 20 ml per kg, then chest auscultation after each bolus. Don't give more than 2 boluses in the ER. This is the recommendation for pediatrics. This is the recent guidelines, which is mentioned in the PICU 2024. Give, and if you need the textbook that or the reference, I may give it to you after the presentation. Give adrenaline and noradrenaline if no improvement after the second bolus. Okay, this is without exceptions unless there is cholera status. Intubate endotracheal tube before the third bolus and prepare for mechanical ventilation is needed, because mechanical ventilation may be needed if your child is not improving. Start mechanical ventilation if your child is not improving after all of that. If you will give the 2 boluses, and then you will give the vasoactive agents, and then you will give the third bolus, and you intubate, and your child will start not improving, then you need to go to mechanical ventilation. Be careful in septic shock and cardiogenic shock. Only 1 bolus could be a cause of pulmonary edema. You have to be careful of that, because it's mainly could be a distributional shock, not hypovolemic shock. When there is suspicion of infection, of course, you need to give the antibiotics. Let's go to our patient. When you try to put urine back to the previous baby, you note small penis. You note small penis. What's the most likely diagnosis of this case? Is it diabetes mellitus? Of course, insulin-dependent diabetes mellitus. Or it's diabetes insipidus? Or it's gastroenteritis? Or it's congenital adrenal hyperplasia? Or hypoadrenalism? This is a real case. Please be careful. I said a small penis. I didn't say ambiguous genitalia. Ambiguous genitalia is not small penis. Small penis, and stop, I mean there is a scrotum and there is 2 testicles inside it. If there is a problem about the scrotum or testicles, I will say that. But if I said only small penis, that means I have the ability to say this is a penis, but it's small, okay? There is only one answer correct given for this case, which is diabetes insipidus. We have to be careful of central diabetes insipidus due to the loss or deficiency of antidiuretic hormone, which is usually associated with such finding. Not only hypoglycemia, small penis could be a good indicator of hypopituitarism when there is hypoglycemia, but without hypoglycemia, if there is severe dehydration, it also could be an indicator of diabetes insipidus. And such a scenario usually comes to you during the summer hot weather. So this is the first case, just to show you not every dehydration, even with vomiting, is gastroenteritis. Please keep that in your mind. And again, we have to remember that shock refractory to IV fluids, 2 boluses, and 1 vasoactive drug, 1 vasoactive agent, is a strong indication for intubation. Not only unconsciousness, the need for general anesthesia, or there is a presence of respiratory failure, or there is insecure airway. This is the indications of intubation according to the recent pediatric PICU guidelines. The second patient, 10 months old infant, has recurrent fever up to 39 since 3 days. Also, this baby has profuse watery diarrhea, and he had vomited 2 times. When you examine him, the child seems alert, not distressed, no pain. His mouth is dry and eyes are dry, but his abdomen is soft and the diaper is wet. His temperature is 39, heart rate 120, respiratory rate 35, saturation in room air 92, and the mean arterial map is 60 millimeter. What's the recommended management plan for such a scenario? For such a baby, first plan is to give oral rehydration solution and give antibiotics and give lactose-free formula and discharge him home. This is the first suggested plan with one of your colleagues. The second recommended plan is to make some septic screen, like taking CBC, CRB, stool PCR pathogen, giving him oral rehydration solution and ondansetron. The third suggested plan is to give him 200 ml bolus of normal saline, plus then move to oral rehydration solution and give him ceftriaxone, first dose. The other solution, D, is to give oral rehydration solution, ask for stool culture and blood culture, and give him zinc syrup. And the last suggested plan is to give him bolus of 200 ml and then admit the patient directly in pedia ward. What's the recommended management plan for this child? Please. Yalla, shares. Very good. Very good. Agree with you completely. All the answers very good. We have a case, an infant who is 10 months old, less than 1 year, who has fever, but he looks otherwise well. He has diarrhea. He is achieved the typical definition of acute febrile diarrhea, an infant less than 1 year, but he is okay. He's not dehydrated. So the first step, we can make a definition for him if he has Phoenix score or no, because he's not dehydrated. There is no Phoenix score. So this child need a primary assessment to see if we need to give him antibiotic or not. The recommended investigations, going with choice B, is to give him CBC, to take CBC, CRB, and stool PCR pathogen if it's available. Start with him oral rehydration solution. If the CBC, CRP, stool pathogen is negative, then we don't need to give him other than oral rehydration solution and 1 or 2 doses of ondansetron. Thank you so much for the correct choice. This baby blood results was CBC 10,000, CRB 12, and as it's less than the cutoff line, he was given oral rehydration solution, as it could be mostly viral. We don't have the ability to make stool PCR, and we sent him home on symptomatic medications. His sister, who is 3 years old, attended at evening with high fever. She also has red sticky eyes and diarrhea once, but she vomited 10 times since morning. She looks ill, apathic, with sunken eyes and mottled legs. Heart rate 140, respiratory rate 40, temperature 39, saturation 90 in room air, and MAP 50. 3 years sister with severe vomiting. She looks very dehydrated and deteriorated, circulation unstable, saturation poor in room air. What should you do now? Give ceftriaxone 1 gram IV and bolus 20 ml per kg, 1/2 normal saline in D5, or give 250 ml bolus plus adrenaline IV, or give 200 ml normal saline with aldosterone, paracetamol, oral rehydration, and send her home, or give 30 ml per kg within 1 hour of normal saline, collect sample, then evaluate for sepsis score, or give 30 ml per kg within 1 hour, then give noradrenal IV if no improve. Choices, please. Very good. Most answers correct. Yes, this child has severe dehydration with severe vomiting and diarrhea since morning, and there is strong family history of gastroenteritis. It's usually infectious diarrhea, and she has severe dehydration, so I need to give 30 ml per kg according to the WHO recommendations. Give 30 ml per kg normal saline within the first hour, then make evaluation for the level of dehydration, Phoenix score, and collect samples. Thank you for the correct answer. Okay. So, oxygen was given by mask, and 450 ml normal saline was given during the first hour. Samples sent for septic screen. Now she is sleepy and respond to speech only. Her temperature 39, heart rate 120, respiratory rate 30, capillary refill time 3, and MAP 55. A mixture, you decided to give her more fluids. A mixture of 450 ml normal saline plus 400 ml 1/2 normal saline in D5, supplemented with potassium chloride 20 millimole, was given at a rate of 90 ml per hour, started. Also, because of there is a suspicion of infection and she's severely dehydrated and the MAP is still low and she's still not responding well, she's still apathic, so she achieved 2 points of the Phoenix. Ceftriaxone was given. I've tried just to discuss with you why she was treated in this way. After 4 hours, the child in the ER, still in the rehydration room on IV fluids. She's alert now. The total oral, she is accepting and tolerating oral rehydration solution. Heart rate 100, improved, decreased. Respiratory rate 25, temperature 38.3, capillary refill time 2 seconds, MAP 70, and saturation room air 93. Now we have the results which taken hours before. Complete blood count, white blood cells 7.5 thousand, CRP 14, lactate 3, random blood sugar 60, and the urine is clear, and stool PCR negative for norovirus. What's your decision now? Admit the patient in PDA floor and give him intravenous fluid plus ceftriaxone, give him oral rehydration solution and send home with paracetamol and eye drops, or give oral rehydration solution plus antibiotics for 5 days according to WHO recommendations, or continue 3 days antibiotics till the stool culture is available, or go with full septic screen including chest X-ray and LP, kidney function, electrolyte, liver function, and others. What's your recommended plan now? According to the plan that we mentioned before, in the management of a child with severe dehydration. Yes, this child improved properly. Her circulation is stable now. Even she's rehydrated for 6 hours. She's stable, accepting oral fluids. No need for antibiotics because the pathogen PCR is positive for the norovirus and the CBC CRP is negative, both of them almost less than the cutoff line. So this child, in spite of that she attended in very poor condition, improved on the primary rehydration within 6 hours. Now she's stable and can be sent home on oral rehydration fluid plus symptomatic medications. Another child. Is it enough, or we can continue? Should we continue or stop here? Continue? Okay. 8-year-old boy has fever 38.3 and vomited 2 times and diarrhea 2 times since morning. This is very important case. Please, I need your attention and cooperation. So 8-year-old boy has fever 38.3 and he has vomited twice and passed losing motions twice since morning. Yesterday, he was very active. He was a picnic outdoors all the day, playing and jumping and eating. Now he's tired. He cannot dress himself or even comb his hair. On physical examination, the child is alert, but he's drooling saliva from his mouth. And he prefers to keep his mouth open when sitting. And when you try to look to his eyes, he avoids to look in your eyes, even if he's talking with you. And he keeps looking into the distance. His heart rate is 110, respiratory rate 15, temperature 38, blood pressure 105/60, capillary refill time 2 seconds, saturation 92. What's your decision now? What's your decision now? What's your intervention first? Sorry. What's your intervention plan? To give him, to make the sepsis alarm and start the sepsis 6 bundle, which is oxygen, antibiotics, IV fluid bolus, and take samples and others. Okay? This is the sepsis 6 bundle. Or to make partial septic screen and admit the child in PDA-FLOR and give him NPO and IV fluids, or to give him oral rehydration solution plus paracetamol and discharge home, or to give him bolus 400 ml normal saline and take sample for CBC CRP and give ceftriaxone, or to admit the child in PICU and order for CT and lumbar puncture. What's your intervention now? Let's go back to the case, to the patient. 8-year-old boy has fever, little bit vomit, little bit diarrhea for 1 day. He looks weak, looks ill, tired, excessive drooling. He prefer to keep his mouth open with excessive drooling. Avoid looking in your eyes, and he keeps looking into the distance. Circulation seems acceptable. Heart rate, respiratory rate on the borderline, but we can't say that he has distress or he has tachycardia, for example. Temperature mild fever, but it's not febrile. We can't say, to say febrile should be more than 38.6. Capillary refill time and saturation acceptable in room air. So this is the scenario. This is the scenario. What should be your intervention? Now, you made a rapid decision, which is not correct. First of all, you have to go to the 3 targets. Go to the 3 targets. This child has severe dehydration or not? This is the first question. To answer this question, you have to go to the recommended plan. This child has severe dehydration? No. He has no severe dehydration. So no need for bolus. No need for bolus, isn't it? Decision. So the decision number D is incorrect completely. Other. Can we give oral rehydration solution? Can we give oral rehydration solution to a child with excessive with excessive salivation, and he prefers to keep his mouth open. So it's not wise to give him oral rehydration. You may cause aspiration for him. He barely swallows his saliva. How you will give him oral rehydration? This is one of the contraindications to give. If there is dysphagia, it's a contraindication to give oral rehydration solution. So choice C is incorrect, definitely incorrect. It's contraindicated even. Yes. So this child, I'm not sure about his diagnosis. But there is some critical signs like excessive salivation. Keep that in your mind. Golden rule, a rule of thumb. Never discharge a child with excessive salivation. Usually there is a critical diagnosis. It could not be clear from the first visit or from the first examination without investigation, but don't send him home, please. It could be pharyngeal abscess, retropharyngeal abscess, could be tetanus, could be tetany, could be a different diagnosis like what we will see in our patient, or could be diphtheria, or could be other foreign body. All of them are critical diagnosis. It's alarming sign. Excessive salivation mostly due to swallowing problem. Don't send your patient home without undiagnosed. Okay, so this patient need to be admitted. This is the first decision. Can I and should be kept NBO? We should never allow him to drink or swallow any oral rehydration fluids or even regular fluids or regular food. And we need, of course, to start with him the maintenance IV fluid. So the correct decision is to go with choice B. Why not E? Because he is not a critical situation to be admitted in the PICU. If I will make a decision, it should be justified. Is it justified for this patient to send him to the PICU or send him for the CT or LP? No, not at all. Okay. 3 hours after admission, the nurse called you that your patient has got 2 episodes of aspiration with cyanosis and apnea. His apnea improved by oropharyngeal suction. When the nurse helped him by the oropharyngeal suction, his apnea and cyanosis improved. There is no cough, no vomiting, and the patient is still NPO. When you come to evaluate your patient, you see that your patient looks dusky, apathic. His heart rate still 110 and respiratory rate 15, capillary refill time 3, MAP 80, and saturation decreased to 85. And still there is excessive drooling. And when you look to him, he's apathic, but he can respond to you in voice, but he still gaze into the distance. In spite of lights in the ceiling, in the roof, he still looking into the distance. When you examine, there is crackles in his chest. It seems there is a lot of saliva and secretions went down to his chest. And despite of that, he can't cough. What's your decision now? Transfer the child to PICU under oral suction and airway protection, or give him oxygen by mask and set him for CT scan with contrast, or make alarm for sepsis 6 bundle, or put nasogastric tube and send him for chest X-ray, or put on nasal CPAP. What's the recommended decision? You are the registrar on duty, and you have no time even to ask your consultant. You have to move. You have to make a decision now. Answers, please. Yes, it's high-level situation, difficult question, difficult scenario, but we are not an exam. We are here for training purpose. More? Look, when you have insecure airway, in such case, you don't have a luxury of time to waste it. This child has insecure airway, as you see. So the correct decision to protect the airway, and you have to make oral secretion, and it's unsafe at all for him to be kept in the pediatric floor. So the correct decision is to protect the airway, make oral secretion, make oral suction while you transfer him to the PICU. Yes. Other choices seems waste of time. So the mouth of the patient was cleared by suction, and the ventilation support by mask and bag started, and the transfer to PICU arranged. In the PICU, he was intubated, and he was put on mechanical ventilation in pressure support mode because of frequent aspiration and insecure airway, in addition to bradypnea. What's the most useful investigation now? What's the most useful investigation to this patient now? Kidney function and electrolyte, urine analysis, and liver function and blood film, Clostridium toxin secrete in stool, Shigella toxin secrete in stool, stool culture with CBC, CRP, lumbar puncture, chest X-ray, MRI brain. What is the most useful investigation? All of them could be recommended. From your point of view, from your clinical assessment to this child, what's the most useful investigation now? So we have a child who is 8 years old with rapid deterioration. There is some neurologic findings, if you see. There is some neurologic findings. He avoid looking in your eyes. There is swallowing difficulty, dysphagia, excessive saliva. He can't dress himself or combing his hair. This means there is weakness in the upper segment of his body, isn't it? And there is some symptoms of the vomiting and diarrhea. One day before he went in a picnic. What does that mean? What does that mean? There is episodes of apnea. It gives only one diagnosis. It gives only one diagnosis. When we look in depth, it goes with the Clostridium botulinum intoxication. So when you find gastrointestinal symptoms, vomiting and diarrhea with ascending paralysis, or followed by ascending paralysis, you have to think about Guillain-Barré. No doubt about that. And all of you, if I made the paralysis processing from down to up, you will choose Guillain-Barré, I'm sure. But when you find gastrointestinal symptoms for hours or 1 to 2 days, followed by descending paralysis, this child has descending paralysis. He has poor accommodation. That means he has diplopia, or he has difficulty in the near vision. He prefers to distance vision. He can't look in your eyes while you are talking to him. So he can't make good accommodation when you are so close to him. This should draw your attention that this child maybe has paralyzed cranial nerves which control the movement of your eyes, of his eyes. And the second one, which is swallowing difficulty, mostly goes with if there is no foreign body, there is no retropharyngeal abscess, there is no clear focus of infection. We have to think about the neurological causes. In such case, we must think about bulbar palsy. Bulbar palsy is one of the early symptoms of Clostridium botulinum intoxication. So please remember, keep that in mind. When you find descending paralysis, starting from head down to the upper limbs and down, then to the respiratory muscles, and then you have to keep that in your mind. We had many cases like that in the previous month, in the last month. Keep it in your mind. This is the typical scenario which was seen. Let's take the last case. Are you interested, or we have to stop here? The last one. Okay, the last one. Saleh, 5 years, has fever, diarrhea, and vomiting since 2 days. Again, we have fever, vomiting, and diarrhea. Please keep in your mind, not all vomiting and diarrhea is necessarily gastrointestinal infection. This is the summary that we have to keep in mind. When there is other signs and symptoms, we must think broadly. So Saleh is 5 years, has fever, diarrhea, and vomiting since 2 days. The diarrhea 10 to 15 times a day, but in small amounts, mucoid with tenesmus and some blood. He vomited 2 times today after eating food. He is alert, not in distress when you examine him, but sometimes there is abdominal pain. The urine, he passed urine 1 hour ago. His heart rate 100, respiratory rate 35, temperature 39, with soft abdomen. His system is intact. You made some primary assessment labs. You find that white blood cells 4,000, CRP 20, and procalcitonin 1.1. You don't have the ability to make stool PCR. What's your treatment plan for Saleh? What's your treatment plan for Saleh? Put him on BART diet plus paracetamol and oral rehydration solution, or give him ciprofloxacin orally with oral rehydration solution and follow the fecal-oral hygiene instructions, or make stool culture and give him cefixime and oral rehydration solution, or admit him in Pediafloor, or give him ceftriaxone plus paracetamol, ondansetron, and oral rehydration solution. One choice is only the correct. I don't have the ability to make pathogen isolation, so I need to go with the WHO recommendations, isn't it? Choices. May we go to the scenario again? 5-year-old boy with severe diarrhea in small amounts, mucoid with tenesmus and blood. There is fever. So I have 5-year-old boy with acute febrile diarrhea, and there is mucus and blood. Okay, but the child seems cardiovascular stable, and I decided to make some investigation to make septic screen, partial septic screen, white blood cells low, CRP relatively high, procalcitonin high. I don't have the ability to make pathogen PCR. What's the recommended treatment? Okay, good. Ahsantum. Best answer is to give, according to the WHO policy, all cases of mucoid bloody diarrhea, best treatment should be ciprofloxacin oral plus ORS and fecal-oral hygiene instructions. Thank you. We will stop here. Before the last slide, before finishing and closing the lecture for today, I would like to remind you with the WHO recommendations for the antibiotics according to the pathogen. When there is bloody diarrhea with fever, go with ciprofloxacin. When there is febrile toxic status, also give ciprofloxacin IV or ceftriaxone in high dose. When there is prolonged diarrhea, give metronidazole. When there is a prolonged diarrhea, give metronidazole. But if there is ability to make pathogen isolation, it's better to make it. It could be bacterial, it could be blind loop, or other causes of traveler's diarrhea. Febrile diarrhea with chronic disease, also you give recommendation is to give metronidazole. Febrile diarrhea with malnutrition, give cotrimoxazole. When there is Shigella, give azithromycin. When there is cholera, give azithromycin 5 days, ciprofloxacin or doxycycline. Thank you so much for your attention. Thank you so much for your cooperation. If you have any point to discuss, most welcome.